I'd like to welcome you all to this special symposium, which is entitled Preparing for New Alzheimer's Disease Treatments. My name's Angela Bradshaw. I'm the Director for Research at Alzheimer Europe, so I'm honoured to be presenting or moderating this session, both with my Alzheimer Europe hat on, but also due to the topic, which is very close to my area of interest and some of the work that we're doing at Alzheimer Europe. So just to give you just a bit of background, so this symposium is independently organised by ourselves at Alzheimer Europe, but we're supported and we're very grateful for the Gold Conference sponsorship that's provided by Eli Lilly. And I just wanted to start with a few scene-setting slides. And these are some headlines that might be familiar to you from the last few years. And we've been hearing these types of sentences and words that are coming much more frequently into the public discourse about Alzheimer's disease and dementia. The start of a new era for treatment, a new era with hope and risk. A new era of innovation, preparing for the new era. How do we get ready for these new treatments, these new diagnostics? And this is why we're hosting this session, and this is why we've chosen the topic for this session of preparing for these new treatments, because they make a significant advance in how we think about Alzheimer's disease and how we think about treating Alzheimer's disease, being the first disease-modifying therapies for a condition that affects over 9 million people in Europe. This session is all about health systems preparedness or readiness. And this is defined as the ability of a health system to promptly and sustainably adapt its policies, infrastructures, and processes to support the inclusion and integration of innovative approaches to care. It's very important, and this definition is actually from the World Health Organization, which is just a few hundred meters down the road. And the value of health systems readiness is that it allows healthcare systems to be more resilient, to deal with shocks, and enables them to perform better, delivering effective, high-quality care equitably and sustainably to people who need it, when they need it. And that brings us to our speakers for today. So I have the great honor to moderate a panel with 4 fantastic speakers representing very different perspectives. First up, we have Jan Runar Eliassen, who is a member of the European Working Group of People with Dementia from Norway, and he'll be sharing his personal perspectives from his lived experience. We have Kath Mummery, who's joined us from the UK, and she's going to explain what is being done and things that should be done when we're trying to translate these innovative therapies from research to real-world clinical practice. Julius, who joined us from from Zurich, will talk about biomarkers. How can they advance and improve diagnosis? And Leonie, a friend from the Netherlands, will tell us about how patient-clinician communications could and should be approached as this new era advances on us. Now, first up, we have Jan Runar. So, Jan Runar, I'd like to welcome you to the stage. Over to you. And here is our technician who's going to help me with the presentation. And just one more thing while we deal with slides. So we've got a fairly short, sweet session, so I will hold questions until the end, if that's okay. So please just scribble them down, and there'll be plenty of time for that once the speakers have finished.
Just push. To that. Yeah. Thank you. Hi, everyone. My name is Jan Runar Eliassen, and I'm from Norway. I'm 50 years old. And I'm married to Marion, a beautiful wife. I have, as you can see, 5 kids. Pretty fancy. At age 45, for 5 years ago, I got diagnosed with Alzheimer's. At age 45, it was a big shock for me and my family. And at the time after, it was hard for all of us, and it comes with lots of uncertainty of what the future would bring. Lots of future dreams and other things was put on hold. I also got the depression, and I used some time to get over it before I tried to be more positive in my approach. In Norway, we are proud of our healthcare, but care regarding people with dementia, we have a long way to go. My family and I didn't get any contact with our local communities for 4.5 years. And this is not an unique story. When I travel around Norway, this is something I hear all over the place. And let one thing be clear. When you get a diagnosis like Alzheimer's, you should not be alone. It should not be up to you to search the internet for information. Alzheimer's should be treated like other diseases, like, for example, cancer. You should be provided the information you need at the different sections of the illness. The one thing that helped me and my wife a lot was the contact we made with or established with the Norwegian Health Association. After a few conversations with them, I was asked to be a member of the working group for people with dementia. That group works pretty similar to the group here at Alzheimer Europe. We have meetings 4 times a year, and that is something Mary and I really enjoy and look forward to attend. I learned a lot from those meetings, and they have helped me to get more knowledge of this illness. In 2003, our national TV broadcaster, NRK, decided to do the same as the BBC and start the Dementia Choir. I joined the production, and my goal was to get a higher awareness of the illness in the society, to show that also the young people can get it. It was a huge success, and over 1 million people watched it, and it's pretty great when you think of in Norway, it's like 5 million people living. Today, there are more than 170 choirs around the country. After that production, I have been invited to many different places around Norway to speak about my life as a young person with Alzheimer. I have spoken to regular people, healthcare workers, students, politicians, and ministers from the government. I'm also an ambassador for Norwegian Center of Healthy Aging. They have many students regarding dementia, and I have been fortunate to visit them to see how they perform their research. I'm also a member of the steering group of young people with dementia in Norway. They have a program that they call Health Skills Course for young people with dementia. This is a course over a year with 6 sit-down meetings and 6 meetings over Teams. Each course, they have different case we are discussing, and yet again, I learn so much every time I attend. I mentioned the Dementia Choir, and after production was finished, the choir continued. And we practice every Wednesday in Oslo, which is quite fun. The last month, and it will continue in the last month, and it will continue until late November. I have been on a concert tour with our choir conductor, Kim. We sing in churches around Norway. Lots of people are coming to this concert, and I have always loved music, but I think it got a whole new meaning for me, and it made me calmer, and I would like to think I'm more focused. I'm pretty sure that having a lot to do helps me in my everyday life. Having an active lifestyle is very positive when living with Alzheimer's, so that is something I strive for. But with 5 children, all of them live at home, and a wife where the wife and children run their own businesses, there is enough to do for all of us. The family loves sports, and the children run a frisbee golf production, so we play quite a bit together as a family. Our common passion is Liverpool Football Club, and when they play matches, we watch together in front of the TV and cheer together. This is one of the first trips to Anfield. And as many of you know, The Liverpool's club song is called You Never Walk Alone. The word in this song is very powerful. My wish for the future dementia care is that no one should feel they are alone with this disease, not the person with disease, neither their families. Thank you for listening, and now I'm going to sing the You'll Never Walk Alone for you. When you walk through a storm, hold your head up high, and don't be afraid of the dark. At the end of the storm, there's a golden sky and the sweet silver song of a lark. Walk on through the wind, walk on through the rain, for your dreams be tossed and blown. Walk on with hope in your heart, and you'll never walk alone. You'll never walk alone. Walk on with hope in your heart, and you'll never walk alone. You'll never walk alone.
Wow. How do you follow that? So all I can say is thank you. Try to breathe, and let's move on to the next speaker. Kath. You don't need to sing, but we can maybe, I have the great pleasure of welcoming Kath Mummery. So Kath is a professor of neurology and a consultant neurologist at the National Hospital for Neurology and Neurosurgery in London. She's also the head of clinical trials at the Dementia Research Centre at UCL, where she's been chief investigator of over 20 clinical trials looking at the early phases of Alzheimer's disease and looking at disease-modifying agents. Kath, the floor is yours.
Wow, I'm going home now. I think, Jan, thank you, first of all. Thank you so much. That was beautiful and unbelievably powerful. I'm also slightly overwhelmed. Also, I think Jan is the first person to successfully convert me from being a diehard Arsenal fan to Liverpool. My husband will never forgive me. Okay, so I'm Kath Mummery. I'm a clinician, first and foremost, and as you heard, I also do clinical trials. So my goal in life is to try and find treatments that make a difference. but also to be able to give those treatments safely and appropriately. If we can't do that, then what's the point of finding the new treatments? So I was asked to talk about moving from research into clinical. And I think there are many challenges and opportunities. I've only got 10 minutes, so we're not going to cover all of them. I'm just going to try and give a flavor of some of the things that I think we should be thinking about and some of the questions that come up when we start to try and move our nice, tidy clinical research into the real world. These are my disclosures. And I was asked to talk moving from research into clinical, but we know that that's not the process. It's not unidirectional. All the questions that come in research come from our patients, come from our clinical scenarios. And so there really is a circular translation. We think about the questions that come from our patients. We try and find treatments or ways of caring for individuals that make a difference to those issues that they have. We put them back in the real world and try to refine them further. And I think that process, that circle, hopefully is a virtuous circle to try and improve and enhance both our clinical and our research. And this is an example, many of you will know this lady. This is an example, perhaps, of where a patient intervention made one of the biggest differences we have had so far in Alzheimer's disease. This is Carol Jennings. And Carol sadly passed away earlier this year, but not before she had made a huge difference to our understanding of Alzheimer's disease and potentially our treatments. She was an advocate throughout her life. But she recognized that in her family, people were dying too young and dying of dementia. And she worked this out. And she went to John Hardy and Martin Rosser back in the 80s and said, look, there's something wrong with my family. You need to research it. And they did. And they took blood, thanks to her persistence, from all of the members of that family. And as a direct result of that, the first gene that causes Alzheimer's disease was discovered, thanks to her intervention, thanks to that one person. And that then led down the road of amyloid is important in the development of Alzheimer's, the amyloid hypothesis, and the focus on amyloid treatment trials. For the first 20 years, almost exclusively. Now, there is a broader portfolio. But we had many years with multiple negative trials, trying to find treatments that would remove amyloid. As you know, we now have 2 treatments fully approved by the US that show clearly, if you reduce amyloid low enough in the brain, you will slow down the course of the disease, albeit modestly. 27% with lecanemab, 29% slowing of reduction with donanemab. Of course, things are more complicated in Europe than they are in perhaps some of the other countries. The EMA have not approved lecanemab and are considering donanemab. In the UK, we've got approval from the MHRA, but we can't give it because it's not cost-effective according to NICE. So we have some work to do to try and sort out our modeling and how we are potentially going to give these treatments. But regardless of size of effect, we've shown we can change the course of the disease. That's a huge milestone, and Carol would be proud of that milestone. That's the beginning. We heard about new eras when Angela was talking. There's a lot of words that are used, but this is the beginning of a change. It's a foundation that we can build better drugs on top of, build better care on top of, change our services. Of course, having new treatments brings more questions than it does answers. There are many, many questions around these treatments, and these are just a few of them. If I was a patient sitting in clinic thinking about these, what would I want to know? When should I have this drug? How long should I take this drug for? How are you going to stop it causing me problems? How are you going to understand what happens to me when I'm not one of those middle-class white people that went into the clinical trials? So there's a huge amount that we don't know yet that we really need to understand, and that's where real-world registries, which have been talked about today earlier on in another session, are going to be absolutely critical. But importantly, what's this mean for our clinical services? And I'll come back to that in a second. But that first question, when's the best time to give these therapies? Well, we only have information from 2 phase 3 trials right now, and some others that perhaps reinforce what we're finding. We know that we can lower amyloid significantly, and associated with that, there is this slowing of cognitive decline with donanemab In the overall group, and that's a combined group of those with MCI and mild AD that either had low levels of tau in the brain at baseline or high levels of tau in the brain at baseline. And I'll come back to why that's important, that division, in a second. Across those groups, it slowed down by around 29%. But if you looked at the low levels of tau group, and that's a group with earlier disease, that difference increases. So you still see dramatic lowering of amyloid, but you see an increase in the slowing of the cognitive decline from 29% to 36%. So perhaps we need to be going earlier. Perhaps it does matter. Perhaps time is brain, that we do need to give these treatments earlier on in the course of the disease. And of course, that means we need early diagnosis. And we're not brilliant at that yet. So I think early diagnosis practically is absolutely critical of a disease, not just of dementia. How long do I have to take the drug? Well, the two trials we've had so far have used different methods, but they both show that over 18 months, we can slow things down. What happens after that is uncertain. But there are people that have been on drug for longer. So in the DIAN-TU trial, and this is a trial with families like Carol's family who have a genetic mutation causing Alzheimer's, in that group, those at risk, they don't have symptoms yet, were started on treatment, and some of them have been on an anti-amyloid immunotherapy for over 10 years. If you look at that group that have been on treatment for over 10 years, and that's that blue line there, and you compare them to the controls, over that period of time, their risk of developing symptoms reduced by 50%. Now, these are small numbers, very small numbers, so take it with a pinch of salt. We need an awful lot more data to prove this, but the point is, potentially, these treatments could be used to delay onset, and potentially by a significant period of time. The modeling on this suggests it could be between 5 and 15 years, delay in onset of symptoms. That's a big difference for anybody. So more information is required, but perhaps we are seeing that over a longer period of time, these drugs make more of a difference. Coming back to our services, in the UK at least, and I know a number of you are from the UK, you will recognize that our services are fragmented. There are multiple specialisms involved, there are multiple trusts involved, there are multiple pathways, and they're primarily community-based and diagnostic-based in that people are not followed up, usually if they're mild cognitive impairment, which is the group we want to think about for these treatments. So having these drugs, regardless of size of effect, is a catalyst. This should be invigorating us, making sure that we make our services fit for purpose. There are other drugs coming down the line. It's not just about these two drugs. There are further things that are going to be showing more and more difference. If you look at MS, the first drugs in MS didn't make much of a difference. Drugs weren't approved to start with until the patient voice had an influence. And now there are 21 drugs approved. They have a massive difference in terms of levels of disability over decades. That's where we're going over time, so we need to make changes now. Making a pathology-specific diagnosis, being able to make a disease-specific diagnosis, not just saying somebody has dementia. Integrating, working together. We're rubbish at this at the moment. We need to get much better, not just across those that see dementia, but those that work in acute medicine that see them in A&E, or when somebody is thought to have had a stroke and they haven't got a stroke, they've got other problems going on. Working together in a multidisciplinary way. Embedding research in clinical improves both. We have to do that better. And reprofiling what we do. Prevention is something, and Jill Livingston brought out the latest Lancet Commission on prevention. Preventing and looking at brain health rather than waiting for dementia is absolutely critical. We need to profile risk from primary care onwards, and we need to be managing those risks so that people aren't thinking about dementia as this end-stage awful thing we can't do anything about. We look after the brain like we look after the heart. If we do these things, then we'll start to move towards chronic disease management, as we do with MS, as we do with all sorts of other disorders. And the most important thing, I think, here, because I'll come back to this point in a second, is that if we do those things, it doesn't matter whether you're eligible for the drug or not. Care will improve, and care will be more robust. So I think these drugs are a catalyst for everyone, regardless of whether or not they get drug. And this is why that's important. A minority of people will be eligible for these drugs. If you look at the numbers from the States, it's between 8 and 10% of their patients with Alzheimer's disease. If you look at the numbers in the UK, in Sweden, in various other countries in Europe, again, between 10 and 15%. So a small number of people, at least initially, will be eligible for these treatments. We cannot forget the vast majority of people that will not be. We have to look after them at the same time. But critically, when we studied this in our local region, what we found was, although those small numbers were eligible, the local memory services, because they don't have access to diagnostic resources, would refer huge numbers because they didn't want people to miss out. So we have to improve our ability in local memory services to access biological diagnostics, whether that's MRI, whether that's spinal fluid examination. Blood biomarkers will make a difference to this, and we'll probably hear about those more in a second, but really important. MRI, I just mentioned as being limited in availability. Can we improve access to this? The reason people can't get hold of it is because it takes a long time and it's expensive. The classic gold standard of how to diagnose is on the left, so you'd have clinical cognitive assessment, 30-minute MRI scan, either a spinal fluid examination or a PET to show that you've got amyloid positivity, because these treatments cannot be given without that, and then you get to diagnosis. That's long, it's expensive, and it's a big burden on the participant as well as anybody else. Why can't you do the scan in 5 minutes, not 30? Why can't you do a blood test instead of those expensive diagnostics? We've been doing exactly that in our clinic for the past couple of years. In everybody that comes to clinic, and all they have to do is have an extra 5 minutes in the scanner and a blood test. They're having those anyway. So this is what those scans look like. One of those is a gold standard 30-minute scan. The other one is a 5-minute scan. It's difficult to tell, isn't it? And we've shown in 200 people so far there's non-inferiority both for diagnosis and for monitoring. And we're rolling this out across different trusts to see if we can use it in different types of scanners and make sure that this is something that we can use to democratize access to MRI. So just before I finish, I think it's really important that we think about reframing with this opportunity, that we focus on prevention, as I mentioned, the Lancet paper, and risk reduction, building resilience in people throughout their life course, not just when they are in their middle to late stages of life. Primary care is absolutely critical in this pathway, but the interaction and integration across primary care and secondary is also hugely important, so that primary care are not isolated. They will need to be triaging these patients through, but they also need to have the feedback back about what's happening with these patients and how we manage them in an ongoing process. Improving diagnostics, making an individual decision about the treatments that are appropriate, which might be disease modification therapy, but equally it is going to include other forms of therapy that we have. They are equally important. We cannot have a two-stage process. This has to be a holistic form of treatment, not just think about the DMT, and there has to be equity of care. If you're not eligible, then you still need to be able to get that level of care. Registries are going to help provide information about the generalizability of these and the safety of these, and they're critical. Learning from people that are already giving the drug, for example, in the States and Japan, and sharing that practice in a way that we don't at the moment, more informally, not just papers. I mentioned at the beginning Carol. That was over 30 years ago that she was responsible for the genetic discovery that led to these initial treatments. We've taken too long, and we've taken too long to be able to help Carol. But perhaps we can help her son, her daughter, and their children in terms of future therapies in a more holistic way. Thank you for listening.
Thank you very much, Kath, for taking us from diagnosis all the way through to what we hope will be a holistic treatment for all people who are living with or at risk for dementia. And actually, I also thank you for mentioning diagnosis and talking a little bit about blood-based biomarkers, because that really neatly introduces our next speaker. So I'd like to welcome Julius Popp. So Professor Julius Popp is from Zurich. He's a psychiatrist and professor for geriatric psychiatry, and he's the head of a research group at the University of Zurich, which really focuses on biomarkers and neuropsychiatry. Julius, over to you.
Thank you very much. So, some of the essential points regarding diagnosis have been already mentioned. So, obviously, I entirely agree. So, now it is about biomarkers. Will they change the game? So, I will focus a little bit on fluid biomarkers because they are most promising now for the next steps. But of course, there are a lot others, other biomarkers that deserve to be mentioned and will certainly provide very valuable information in the future. So I will repeat it because I think it's really important. So we have the clinical presentation with cognitive decline, and we have a lot of possible causes, and Alzheimer's disease is one, the most common in older people, but in particular at early clinical stages, it is very difficult based on clinical assessment, neuropsychological assessment, also structural imaging, what is more largely available, to have a sufficiently accurate diagnosis, in particular at the early stages. And we all agree that an early and accurate diagnosis is very important, and for therapies targeting specific pathology is even mandatory. So, but even for the others that will not, which are not included in the minority that are eligible for the anti-amyloid treatments, it is really very important to have an accurate diagnosis as soon as possible, and to at least to have it available, and then to decide on an individual basis whether it's the right time or one should wait. So just to summarize a little bit the Swiss recommendations for diagnosis, which are largely not entirely, but largely similar to what is done also in all European countries, I guess, and which combine actually in the first place clinical and neuropsychological examination, and also standard blood assessments and structural imaging to look for possible causes of cognitive decline and dementia. And also, the biomarkers we are talking about, which are, I have mentioned here, some of them. There are also others, of course. I've mentioned here those which are more specific for Alzheimer's disease, which are most commonly used, and that we use not in all patients coming to the memory clinic, but on the basis of individual indication and agreement, of course, with them, with their needs and preferences. So this is already part of what we are doing today, so that we consider doing biomarker testing in people also not only on the stage of dementia, but also at very early clinical stages. This, in our opinion, is also something that should be always considered in patients, in people with cognitive impairment, which ask for an evaluation. So this should be made available. The question is, of course, does it make a difference? So is it a game changer at the individual diagnosis level? So, and several studies have shown that actually it is testing for biomarkers testing is a game changer, and it changes. So this is a very recent publication. It's not the only one, but I think it's one I would like to recommend to have a look on, because it shows for different questions, for different aspects that actually doing biomarkers reduces, so improves the decision-making on further diagnostic steps, and also on how to counsel the patients, actually the people asking for this evaluation, and how to use AD drugs, for example, to use them if they are more appropriate, or to not use them, actually. And this decision-making actually is largely facilitated, which makes a difference in terms that a decision is made. So otherwise, physicians may decide, or also patients may decide to wait and to not treat yet. So it makes a difference, and it is important to offer the biomarker testing in general, I would say, and then to evaluate, of course, in any single situation whether it is appropriate or not. So the biomarkers make a difference. So I think this is an important point, but also they have important limitations, and there is a risk of misunderstanding here, of course, because if you have a clear biomarker result, this may sound like the diagnosis itself, and we don't think that this is a diagnosis, but this is one important aspect to be taken into consideration, and the result that should be considered in the whole context of the situation, of the individual situation, and to be considered also in relation to the cognitive impairment present, but also to other aspects that may interfere. And of course, it is only a marker for a biological process, and the clinical presentation, the situation of people affected by cognitive decline or dementia is much more complex in terms of causes and factors contributing. So, of course, this is not the same. So having a clear biomarker diagnosis, it is not the same as having a diagnosis. So it needs to be something more holistic, I would say, as an approach. And biomarkers should be part of this approach. Another very important limitation is that actually we are doing now, in a large majority of people affected, people with cognitive decline, we don't do this diagnosis and diagnostics, and we don't do biomarkers. So in Switzerland, a large percentage of the people developing cognitive decline dementia have not very detailed and not a biomarker-supported diagnosis. So this is related, of course, to the limited availability of those biomarkers. Lumbar puncture is required for cerebrospinal fluid analysis, and also this cannot be done by everyone, and people may prefer not to have this quite invasive procedure, but also PET is not available easily. It requires also specialists and specialized centers to do this. So we will clearly need much more those biomarkers if we want to treat patients with AD pathology. So we need to detect this. So for the new drugs targeting specific pathologies, it's obvious and it's mandatory that we need we do the biomarkers testing. So the question is about the resources, and there are a few publications, very recent ones, related to this aspect, and we estimate, so a recent one from Germany estimates that the waiting time for such procedures will increase to up to 50 months for the diagnosis. So if you have to wait 50 months to get a diagnosis, this is really something which is not acceptable. We need to find solutions to improve this, and of course there will be this is also an opportunity, as it has been mentioned, and we should take this opportunity and adapt the health system. So what about the new biomarkers from blood? So actually there were also a lot of publications in the last years with quite spectacular results showing that we may not need the cerebrospinal fluid biomarkers, at least not in the first place, but we may do first blood biomarkers and blood biomarker testing, and with this we may be able, so this is a diagnostic path proposal, so that we first classify the likelihood of having the AD pathology as high, intermediate, and low, and according to this classification that we decide on further steps. So this may be really a quite radical change in the way we deal with, deal with the diagnostics in patients that may have, in people that may have an Alzheimer's disease, in particular at early stages, and this may lead to reduction, to an important reduction regarding healthcare and so resources in general, and also, of course, limiting the diagnostics for the single patients. So is it possible to use this even in the primary care, in real life? And this is another study published very recently. It is one study, but there are also others suggesting that actually the blood biomarkers may be as interesting and useful as the CSF biomarkers or the amyloid PET in increasing the confidence we have in the diagnosis and improving the decisions to be made regarding further diagnostic steps and therapy. So in this study, the accuracy actually of diagnosing AD pathology based on clinical evaluation, also brain imaging, was quite low. As you can see, 61% in primary care and 73% in specialized centers. So even for specialists, the likelihood to be right for the regarding the diagnosis is quite low, actually. So it's high, but it's not high enough actually to be satisfied in the single situation to be confident enough for further decisions. So, and with this biomarker combination in this study, the likelihood increased to around 90%, so which is quite spectacular. It needs, of course, confirmation, but this may change the way we do diagnosis, and we may do diagnosis in primary care if this is confirmed, and in terms of a first step which may facilitate decisions for further steps, in particular in specialty care. So it seems that the new biomarkers, which will probably be available quite soon, actually, will change the game too, not only at the individual level, but also the way we propose the diagnostic journey for people seeking for diagnosis. So what can we do? How can we seize this golden opportunity, as you said? So we need to think about a lot of changes which are required, and the main goals will be to provide an appropriate diagnosis. So if this is available, if the blood biomarkers are available easily, so the question is how to use them in a way which makes sense and which doesn't cause misunderstandings and false decision or wrong decision making. So we need a counseling related to those biomarkers. We need to make sure the quality of biomarker testing, not only in terms of a lab measure, but also in terms of interpretation of counseling, is provided. And so quality, I think it's an important point. And the other important point is how to deal with the resources, which will be still limited, which will probably be challenged also because the number of people doing this biomarker testing, possibly also without any cognitive symptoms, will probably largely increase. And the question is how to deal with this situation. And therefore, we think that collaborations and developing guidelines, recommendations for how to use those biomarkers, how to use them also not only in relation to the new therapies, because there is the first first situation, first setting where we may think it will be necessary, but also for the other people not eligible for such therapies, how can we deal with the potential those biomarkers have? So this will be the question, and of course we don't have the answers yet, but we are working on it. And with this, I would like to summarize, but I will not go through all the points that you already heard. I think biomarkers are the new biomarkers, but also the already established are game changer, and they will be more and more game changer in the new era we are facing now. Thank you.
Thank you very much, Julius, and thank you also for mentioning in the earlier slides that a very important part of having these new biomarkers, fluid biomarkers, is providing counselling at the point of diagnosis and post-diagnostic support. And I would therefore like to introduce Leonie Visser from the University of Amsterdam, but now at the University of Utrecht as well. Yes. So Leonie has a master's degree in medical psychology and a PhD, during which she studied the topic of patient and physician communication, and her work recently has really focused on optimizing that communication to make sure that they are co-created and supportive and inclusive. Leonie, over to you and the technical person who will help me change the slides. Yep. Or maybe I'll try myself. This should be interesting. No, here we go, expert.
Thank you, and considering time, I will just start already by thanking Alzheimer Europe for inviting me into this session, and hopefully keeping you all in time for lunch. Perfect, thank you. Yes, I'm going to talk about clinician-patient communication and make a plea to embrace patient engagement. These are my disclosures. And I think we all know that clinician-patient communication is key. And from a medical communication field, we often use this model in which a clinician-patient communication could have 6 goals. From a clinician standpoint, this is, for example, fostering the relationship, providing information, but also responding to emotions. And if done adequately, clinician-patient communication could lead to beneficial outcomes. Immediate outcomes, such as, for example, patients' expressions of their needs in consultations. Intermediate outcomes, for example, being able to come to the right diagnosis. And long-term outcomes, such as health or quality of life. And of course, these outcomes are now presented from a patient perspective, but outcomes could also be defined as from the perspective of the clinician, or to the process or context or organization, for example, healthcare use or costs. But when we embark on this new era, which the others already talked about, there's also communication challenges. There are more tests, there's this distinction between a syndrome diagnosis and an etiological diagnosis, and there's advancements in treatments. We talked today about disease-modifying treatment, but maybe multimodal prevention interventions also come to the clinic soon. So there's more information and complex information. There might be some linguistic confusion, because I know that in clinics, not everyone is yet on the same page. and there is a lot of uncertainty. For example, about risk information, ambiguity of test results, which was already spoken about, and in general, the future of an individual is hard to predict. So this is difficult to explain and to comprehend, and often there is not one best option, no one size fits all. So we thought, let's talk to relevant stakeholders and collect their perspectives on the most important topics to address, and what tools would support a meaningful discussion on whether or not to initiate this disease-modifying treatment. Or in short, what information needs to be shared and how. We conducted semi-structured interviews with Dutch professionals, people who visit the memory clinic. For this presentation, I refer to them as patients and their accompanying care partners. And we asked them questions such as, how would you communicate with your patients about disease-modifying treatments, or what questions would you have for your doctor? We also talked to advisory board members in a workshop that we conducted with Alzheimer Europe last year in November, and we developed some tools in co-creation, and hopefully I have some time to show them to you. The themes that came out of these endeavors were that there's quite a lot of ambivalence. There's hope on the one hand, but also uncertainty, risks, and a burden on the other hand. For the communication process, shared decision-making was often mentioned. And this requires an exchange of information. So, of course, a clinician needs to share information about the pros and cons. But on the other hand, patients and their loved ones also are required to share information about their needs and their personal situation and circumstances. Many communication challenges and recommendations were brought up, and tools and training were considered helpful. And when we then overlay these results onto the 6 goals or functions that I previously mentioned, fostering relationship is really important, and trust was often mentioned in this treating relationship. Gathering information is important, and for patients and care partners' perspective, it's about sharing information about who am I, what do I need, what is important to me, and for clinicians to evaluate their prior knowledge. It's about tailored information provision. Maybe use multiple sources and multiple moments, and the GP was also often mentioned as a partner in these discussions. Shared decision-making is essential. This is a team effort, and maybe not only the memory clinic physician, but also, for example, that GP or a nurse could be important in this. And it's relevant to consider that people need time to think. And then when we talk about behavior, people really express that the practical side is important. So how does this treatment influence my daily life? Can I still use it in combination with my other medications, for example? What could happen when I'm home? Do I need someone by my side all of the time or not? Do I need someone to drive me to the hospital? And they express that other options to cope with the disease are also important, so that you can provide the alternatives. And then when it comes to responding to emotions, I think sometimes this is overlooked, but these conversations are confrontational. It's also about disease progression and about that these new treatments cannot cure the disease. So this is also bad news, and a lot of uncertainty needs to be shared. So when we look at this model, you can really imagine that these conversations are difficult and challenging, but really important. A lot of tools were therefore suggested. It's a really busy slide, but it shows you that people had a lot of ideas about what could help. Tools that could be used prior to these conversations, afterwards, or even during the consultation or discussion with the medical professional. Tools suggested for patients and their care partners, but also for memory clinic professionals. And I highlighted a few because we use these suggestions to develop a couple of tools, which you can find on this website. It's ADAPT, and it's a platform that we developed in Amsterdam to help healthcare providers, patients, and their families to enter into meaningful discussions about the diagnosis and treatment of Alzheimer's disease. On the treatment page, there is an information page that everyone can look up. It's a summary about these new treatments with an animated video that also has subtitles, and more detailed information can be found below. It's short sections. We try to use simple language. We included a patient case with a graph to explain the potential benefits, and use, for example, these visual risk displays with neutral framing, so also showing the chance of not getting side effects, for example. And for professionals, we developed a calculation tool based on modeling work of my colleague Peter van der Veren, that you can actually calculate the personalized disease progression for your individual patient and display the potential treatment effect onto that. So you enter your patient data, and then there's two different visualizations. There's a line chart that shows you the expected cognitive decline over a period of 5 years, and there's a time to chart, which shows you the time to a chosen MMSE endpoint. So, for example, if your patient now has an MMSE of 28, but you want to know when this patient might have an MMSE of 22, you can calculate the time predicted. And you can show the treatment effect, for example, the 27% decrease in cognitive decline into these graphs. And in the patient explanation page, there's actually actual texts besides that too. So you can use, the clinician could use these graphs to explain and enter into a discussion about the treatment effect and if patients would find that valuable or not. And because we know that some people like the one graph and some people like the other graph, there is also an option to choose between both of them and print the one that the patient and their care partner like the most. So to sum up, I think it's really important if we embark in this new era to really embrace patient engagement, to do further research to generate evidence-based communication recommendations and tools that would help people to actively be involved in their own personal health care, but also to stimulate engagement of patients and their care partners in guideline, policy and tool development, and in research in general, because their say is important. And to improve our efforts to engage the public, those at risk, I think all of us, for example, when it comes to communication about dementia risk and prevention. And with that, I'd like to close, and I would also like to draw your attention to another session this afternoon in which I will explain a little bit more about the patient and care partners' perspectives. Thank you.
Thank you very much, Leonie. And unfortunately, we've run out of time for questions. So I'm just going to finish just with a very short summing up. And I'd like to thank all of the speakers for really helping us to answer that question that we started with. So we started with the idea of preparing for new Alzheimer's disease treatments. What does a new era look like? And we heard from Kath about what happens when we think about moving these research treatments or treatments from research into clinical practice. How might that look? Who could be eligible? How could they receive the treatments? Julius told us about diagnosis and how fluid-based biomarkers such as CSF and blood-based biomarkers might change the game and speed up the diagnostic process, but highlighting the need for counselling. And Leonie there just finished with a really nice summary of some of the things we can practically do and the importance of involving people with lived experience in creating these tools to support communication and patient engagement. And I wanted to give the final word to Jan Runer, and I wanted to ask Jan Runer, we have this new era that's just on the horizon and these new treatments. When we're thinking about new treatments, what do you want from a new treatment? What do you want to preserve in your life? And what do you want to gain from a new therapy?
The best thing would be that I could be healthy again, that the Alzheimer just could go away. But I know that's difficult, so if I could just have a medication that is easy to take, that I could take at home, and that could provide that I had as normal life as possible, that I could go to work someday again, maybe do all the activities that I love now, and I do it for a long term, and see my children grows up and some grandchildren, and yeah, the normal stuff.
Thank you, Jan.
There we go. So there we have it. We have our mission, and now let's get to work. Thank you all.